So I take the opportunity to invite Dr. Kim, how diabetic retinopathy telescreening has improved timely management. He is currently the president of Telemedicine Society of India and also the chief of Retina Arvind Group of Hospitals. Thank you, Kim.
Good morning.
Thank you,
everyone.
Dr.
I
Natarajan.
thank
President
AIOC
of
for
VRSI.
giving me this opportunity to
President of VRSI.
present
Yeah.
evidence and experience.
At the outset, thank you for inviting me to be a part of this symposium. A topic of importance for all the ophthalmologists. My topic is on how DR telescreening has improved timely management. I'm not sure whether most of my talk is on the diabetic retinopathy screening, not so much on the outcomes, because as Dr. Raji Raman pointed out, I'll come to that part when I say. So we do know that the burden of, I think Rajiv really brought out the epidemiology, the prevalence of diabetes and diabetic retinopathy in our country, which really shows the importance, especially for the retina people, because the amount of problems that we need to manage is so huge. The overall prevalence of diabetic retinopathy from the Smart India study was around 12.5%. And he showed that the vision-threatening diabetic retinopathy above the age of 40 is about 4%, which means we really have a huge problem, and there's no difference between the rural and the urban areas. We all know that the early diagnosis is very important in these patients, and only then you can have retain the patient's normal vision forever. So we also know many studies have shown that the patients, and you yourself would experience, when patients come to you with diabetic retinopathy, it's only at the late stage, not at the early stage of diabetic retinopathy. So what should be done? Can only the ophthalmologists screen for all the diabetics for diabetic retinopathy? We have to find other ways, which means the target population of diabetic patients are seen mostly not by the ophthalmologists, but by the general physicians, diabetologists, and endocrinologists. They are the people who have to own the process of identifying, and today that is very much possible that they can screen patients. At Arvind, we have been doing this screening camp for almost 25 years now, 24, since 2000 we have been doing this, going into the community, screening patients, diabetic patients. What happens is we work with the local physicians to identify the diabetic patients from the community, and then we screen those identified patients for diabetic retinopathy, and this has been going on. We continue to do it even today. Every week we continue. This was some data which showed that the new diabetic retinopathy identified in these process was around 70% in all the patients that we screened. What it means is there are so many people out there who are not identified, who have a normal vision, and every one of us have to take that responsibility of identifying patients, not just finding patients who are walking into our clinic. What is it that we can do beyond this? Because we know that this is an epidemic that is happening of diabetes. How do we ensure that every patient, at least their vision is prevented? As ophthalmologists, we have to do it. The challenges of doing these screening camps, of course, there's a lot of demand on resources. It's not possible for everyone to do it, but where possible, you should screen the patients as much as possible, because here you need the resources like doctors, paramedical team, local facilities, support systems. More importantly, financial burden, because there's no return on investment on this. There's no direct return on investment in the process that you do into the community. So telemedicine seems to be an answer to this problem of creating access, screening patients opportunistically whenever they walk into diabetic clinics or the physicians' clinics. So we've been doing the screening for quite some time now, using telescreening again for the last 20 years, where the diabetologist clinic technicians are trained to use the fundus camera. They take the pictures, send it to the reading center in our hospital, a retina specialist or a trained grader would look at these images, create a report and send it. So only those who have any retinopathy are referred to the ophthalmologist, while the others are asked to come on a yearly checkup. There is some amount of awareness created among the patients in the diabetic patients. The diabetologists also become aware that they have to do this, and then it's definitely a value addition to the service that they do. So again, through these, in 1 year, we were just looking at data, I'm just putting random data, where we showed that the new diabetics retinopathy identified who never had any retinopathy identified or their fundus examined was about 68% in this that one period. We also had ISRO had given us a mobile van. Both Shankar Netralia and Arvind had these mobile telescreening van in the early part of 2000, and somehow it lost because of the technologies that have changed with time. The same process was done. The bus would go, find diabetic clinics and bring their patients into the bus, screen them, and then the process of telescreening was done. And again, the new diabetic retinopathy identified, because this was going into many of the rural communities, and we were able to identify almost 85% new diabetic retinopathy patients. What are the challenges in telescreening? Putting the physician to asking them to make this value addition for their patients, it is still a challenge. Very few people are willing to do that, though they know that this will be a very good the necessity for their diabetic patients. Using a retina specialist time is again a problem, inconsistency in grading, which that Rajiv pointed out. And it takes a period of 2 to 3 hours for this, and it's not available 24/7. So again, Dr. Rajiv showed how AI can help. Just a simple algorithm can grade the diabetic retinopathy within a few seconds and give you the report. And this has been, we have been using this for quite some time since 2019, where we have replaced the AI tool. So the physician, without our help, is able to screen that. And then both of us at Shankar Netralia and Arvind, we have done multiple validation studies using this algorithm to show that this algorithm is comparable or better than a retina specialist. More importantly, it is consistent and available 24/7. So since then, we have deployed this in real time. We have been screening these patients in the last 4 years, and we screened about 700,000 eyes. And we found that the referable DR was around 7%. Referable is any DR which is more than moderate or more than moderate or referred, and any ungradable image becomes a referable DR. Again, this similar process is done at Mohan's Diabetic Center on a regular basis. This is Dr. Rajalakshmi's data, where they also show about sight-threatening retinopathy is 7%. The reason for this is because they are looking at, it's in the diabetic clinics they are doing the screening, which means you have concentrated diabetic patients, not in the general community. So that is the reason the number still happens to be higher at 7.3% in the sight-threatening retinopathy. This is another data that I just looked at before we started using AI versus after using AI. We found the difference for a 1 year period. I looked at it, similar number of patients who were screened. The number of diabetic retinopathy identified was around 1,090, whereas after the deployment of AI, the numbers seem to be very high, almost went about 8 times, which is tremendously very, very high. Are we missing? So we are just looking at analyzing that data at this point of time to see. This was just a few 3 months data that we looked at. So we need to look at a larger number of data. How AI is making such a big difference in identifying, because it even picks out those small microaneurysms which is not normally seen by the human eyes. So it is definitely making a difference in the way we identify these diabetic retinopathy. Now, when you look at the evolution of this whole DR screening program, we have come a long way from doing camps, using mobile vans, to today using it on the spot in the physicians' clinics, using it and opportunistically wherever possible, be it medical labs. We have tried it using it in the labs, wherever the diabetic patients would go to buy medicines, even medical shops. We have run these screening programs and continue to do so in most of the diabetology clinics so that every single diabetic patient is screened. What has made this possible? Of course, the opportunistic screening, available of low-cost fundus cameras, availability of the broadband internet, and deploying a basic fundus camera with AI today helps in identifying this. This is again our own short 3 months data that I looked at, how many patients referred and how many patients actually visited the base hospital. If you look at it, it is 70%. Now this, what Rajiv said was around 10% to 70%. I agree with Dr. Rajiv because the 70% is literally pushed in many ways for the patient, facilitating the patient, calling the patient, making sure that they come and visit the hospital was done. Otherwise, it would still remain at 10% because I still have the data where we have not done that. The response is very, very low. This has definitely increased, the telescreening has increased in the country due to improved awareness involving other stakeholders like diabetologists, technology, innovations, availability of low-cost fundus camera. Has this increased the timely management? It is a big question mark. As I said, even upon identifying high-risk patients, securing their cooperation for subsequent follow-up and management is still a big challenge. Lack of awareness among patients and even healthcare workers, including doctors, is still there. Though it has improved, it is still has to be improved in many ways. And of course, as again Rajiv pointed out, the financial burden, unlike cataract, it's not a one-time management. The patient has to continuously follow up. And this, we have to find ways to reach out to these patients and ensure that they get the timely management. So with use of technology today, I think every one of us can easily reach out to these patients. So how do we reach out to those patients who are not walking into your clinic? It is our responsibility as ophthalmologists to ensure that every diabetic's eye is preserved. Thank you, sir.
Thank you very much, Kim. Actually, your Arvind's and Yashan's efforts are really very good. However, what shortage I see is there is no continuous existing facility for the population to avail the facility. Here, if I see your presentation, what I can understand is definitely AI is up the detection by 8 times, which is very commendable. However, if you see the sight threatening, it is 1.4% RPDR, which we can prevent by timely laser. So would you think anything which the society-based facilities or some screening availability? Because today you will go, you will detect and come back. But what will happen to the future?
That's what. Once you you should have some kind of a national program for screening. Ensure every PHC has these facilities. As much as they identify diabetics, they should be able to screen these patients. One, you could do the screening, but we need to ensure that we complete the loop. That means the patient should have a place to go when they have some sight-threatening lesion or even any diabetic retinopathy. They should be able to go and get access to treatment. So these are still lacunae there, but we need to build up on that, sir.
Compliance. It is again, after coaxing it is 70%, otherwise it is 10%.
Yes, definitely it is very, very low.
What will we do for that?
No, we need to create the awareness. It has to increase because people, it is much better than where we started. I think today, if from VRSI, there's a lot of effort that is happening, working with the RSSDI, the Diabetic Association. We are trying to see how to move this screening at the national level using the RSSDI members and creating awareness among those people.